Now we are going to start with hematology. The first chapter in hematology is the drugs acting on the blood flow. Now, as you know, if there is any injury to the blood vessel, now see here, when there is an injury to the blood vessel, what will happen? The platelets will come and try to form a clot or a thrombus. Let us see how is this happening. So, whenever there is an injury, first the platelets will come and attach to that site. That is what is known as platelet adhesion. Platelet adhesion. Now, first some amount of platelets will come, but we need a large number of platelets for the clot to form. That is why these platelets will cause secretion. They will secrete a lot of factors which will attract a huge number of platelets. Now, all of these platelets has to aggregate in between themselves. That is what is known as platelet aggregation. This is what you can see. The platelets are joining together. Now, let us suppose this is the next step that is happening. First, there is adhesion, then there was secretion, and then there is platelet aggregation. Once the platelets are aggregated, you can see here, between the platelets, we have something known as fibrinogen. Now, if you want to form a stable clot, this fibrinogen has to be converted into fibrin. This fibrinogen has to be converted into fibrin. This is what is known as coagulation pathway. Coagulation pathway. First there was platelet aggregation, then there was coagulation. Once this clot is formed, this clot will come and attach here. You can see here. So this is how clot or a thrombus is formed. Now, how many types of thrombi do you know based on the location? You will have something known as arterial thrombi. Arterial thrombi means the thrombus is present in the artery. If it is present in the artery, the thrombus is mostly made up of platelets. So, will you use the drugs acting on the platelet or coagulation path? Obviously, the drugs acting on the platelets. That is why we tend to use antiplatelets for arterial thrombi. Examples are CAD, coronary artery disease, and stroke, because these happen in the arteries of brain and heart. Did you understand? So, in the brain it is stroke, in the heart it is coronary artery disease. That's all. Now, that is about the arterial thrombi. Now, we have something known as venous thrombi. In the veins, the fibrin content is more in comparison with the platelets. So, you would want to use anticoagulants. So, that is the reason why we will use anticoagulants in the venous thrombi. Now, the examples are deep vein thrombosis, because it is happening in the veins. Yes. Now, we have something called fibrinolytics. Fibrinolytics means this will break the fibrin after formation itself. After the fibrin is formed, these fibrinolytics will break this fibrin. Where do we want it? We use it in a condition called STEMI. You must have heard of a drug that is known as streptokinase. Yes, streptokinase. We use it in STEMI. These are fibrinolytics. So basically we have antiplatelets, anticoagulants, and fibrinolytics. In arterial thrombi, we are using antiplatelets. Venous thrombi, we are using anticoagulants. So, first we will start with the antiplatelets. You can see here, these are the drugs. You must have studied it so many times. The first class of drugs is COX inhibitors. COX inhibitors will block thromboxane A2. The drug is aspirin. We've already studied all about aspirin and autocoids. Yes. Now, coming to ADP blockers. Yes. Now, ADP is a molecule which acts on P2Y12 receptor. So, if you are blocking this, if you are blocking P2Y12 receptor, what will not happen? This platelet aggregation and all will not happen. So, the drug names are clopidogrel, prasugrel, ticagrelor, and cangrelor. Clopidogrel, ticagrelor, cangrelor, all of these are P2Y12 receptor blockers. Now, coming to the thrombin. Yes, thrombin also acts on PAR receptor. You can block this PAR receptor. How can you block this PAR receptor? With Vorapaxar. You can see PAR. So, PAR receptor is Vorapaxar. GP2B3A blockers. These are epsiximab, eptifibatide, and tirofiban. Yes, at least remember epsiximab. Now, so COX inhibitors are aspirin. Next, P2Y12 receptor blockers are clopidogrel, ticagrelor, and cangrelor. PAR receptor blockers are Vorapaxar. GP2B 3A blockers are Epciximab. That's all. These are all the antiplatelets that you need to remember. Now, coming to the anticoagulant, one that is really famous is Warfarin. How is Warfarin working? It blocks vitamin K epoxide reductase. Yes, it will block vitamin K epoxide reductase. Now, it can be used orally and onset of action is after 4 to 7 days. It works only after 4 to 7 days. But within the first 2 days, what will happen? There is something known as protein C. It is an anticoagulant factor. When this decreases, it can form thrombus in the lower extremities. Yes, so it will give you this necrosis pattern. This is what is known as purple toe syndrome. So it will cause something known as purple toe syndrome. Did you understand? It will cause purple toe syndrome. Now, it is contraindicated in pregnancy. It is contraindicated in pregnancy because it will cause fetal warfarin syndrome and hemorrhagic disease of newborn. So, warfarin is generally used for DVT prophylaxis in the olden days. Nowadays, we are preferring something known as NOAC or DOAC. We will talk about it. Now, why we are not preferring warfarin nowadays? Because it needs continuous monitoring. How do you monitor this warfarin? You monitor it with the help of PT-INR. You do PT and INR. Yes, we give most importance to INR. And what is the target range? When a person has thrombus, what is the target range of INR? INR has to be somewhere between 2 to 3. That is the target range. Now, if INR goes to more than 3, what will happen? There might be chances of bleeding. Yes, because you are stopping the coagulation pathway. So that is what, if there is warfarin dose and if the INR is going above the target dose, what will you do? See, according to Goodman and Gilman 13th editions, what are they saying? The textbook is saying that if INR is above the target range, you stop warfarin, and once the INR comes into the target range, you restart warfarin at lower doses. This is what they are saying. Now, they are also saying if INR is more than 10, that is when you start vitamin K. Now, doesn't matter what is the INR, if there is bleeding, then you have to give 4-factor complex. What are those 4 factors that you have to give? See, warfarin is blocking 2, 7, 9, 10 factors. So you have to give these activated factors 2A, 7A, 9A, 10A. This is what is 4-factor complex. Along with this, you also give vitamin K. Why? Because vitamin K effect will take some time. Yes, when there is bleeding, you have to give already activated factors. Those are 4-factor complex. So this is what the textbook is saying. When the INR is more than 10, you give vitamin K. But if there is bleeding, you have to give 4-factor complex as well. So this is about warfarin. In anticoagulants, we were finished with warfarin. Now, what you need to remember, there are 10A blockers and 2A blockers. 2A means it is also known as thrombin. What are 10A blockers? It is given in the names. See, 10A, XA. When you are blocking it, you are banning it, or it is also known as antagonist. So these are known as hexaban. So these are apixaban, rivaroxaban and edoxaban. So these are 10A blockers. Easy to remember, all of these are oral drugs. Now coming to 2A blockers, these are thrombin inhibitors. In this you have 2 classes of drugs. One is direct, the other one is indirect. Direct means it directly blocks the 2A. It directly blocks the 2A factor. Yes, this is what I want you to understand. Now, direct, we have both oral and IV. Please remember the oral one, more important, it is dabigatran. D for D, it is direct, it is dabigatran. Yes, in indirect, you have argatroban and bivalirudin. Yes, argatroban and bivalirudin. These are the IV drugs. Now, if you see carefully, it is given in the name. Everything is given in the name. Thrombin means TR, thrombin antagonist. See, troban, thrombin antagonist. That's all. We are finished with the direct thrombin antagonist. Now, indirect ones. Indirect ones are the most famous ones. These are heparins. Yes, Unfractionated heparin, low molecular weight heparin. Next is fondaparinux. That's all. Now, what I want you to remember is in both 10A and 2A, we have some oral drugs. All of these oral drugs together, these hexabans and dabigatran, both of them together are known as DOAC or NOVAC. Yes, DOAC means direct oral anticoagulants, NOVAC means novel oral anticoagulants. Yes, so these are oral 10A inhibitors and oral direct 2A inhibitors. Why are we preferring this? Because it does not require any kind of monitoring. Yes, now coming to the drug of choices. Yes, what is the drug of choice for prevention or prophylaxis or of DVT? DVT is a venous thrombi, so you will use anticoagulants. Yes, obviously you have to give a oral drug. Will you give warfarin? See, warfarin requires a lot of monitoring. That is why you will give DOACs or NOVACs. If you don't have DOACs or NOVACs, then you will give warfarin. That's all. Before it used to be warfarin. Now we are preferring DOAC and NOVAC. Now, drug of choice for acute treatment of DVT. Here you have to give an injectable form, that is heparin. Low molecular weight heparin you will get. That's all. This is about the DVT. Yes, you understood this much? Now, coming to the antidotes. What is the antidote for warfarin? It is vitamin K. Now, what is the antidote for dabigatran? It is idarucizumab. Yes, what is the antidote for XA blockers, 10A blockers? Yes, these are hexabans. What are the antidotes for this? What is the antidote for this? It is andexanate alpha. For heparin, it is protamine sulfate. For HIT, heparin induced thrombocytopenia. For HIT, what do you give? Argatroban. Now, there is a non-specific antidote for all the anticoagulants. What is this? It is ciraparantarac. Yes, this is the non-specific antidote. It is not FDA approved as of now, so that is why I didn't give too much attention to it. But you have to remember all of this. Warfarin is vitamin K, heparin is protamine sulfate. 10A blockers are andexanate alpha. It is given in the name 10A. Yes, XA, hexaban. You will also give andexanate alpha for hexaban toxicity. Yes, that's all. Now, coming to hematopoietic agents. That means these are increasing the blood cells. Now, to increase the RBC, you can give erythropoietin. Yes, increasing RBC is what is known as erythropoiesis. You can give erythropoietin analogs. So, everything is given in the name. E-poietin alpha, erythropoietin. Darbopoietin, it is erythropoietin. Given in the name, I told you. So, next coming to granulopoiesis. That means you want to increase the WBCs. How can you increase the WBCs? You can give colony stimulating factors. Yes, one is granulocyte colony stimulating factor. The other one is granulocyte monocyte colony stimulating factor. This is GMCF. This is supposed to be GMCF. One is filgrastim. The other one is sargramostim. How do you remember? Grastim, granulocyte stimulating factor. Gramostim, granulocyte monocyte stimulating factor. Did you understand? GCF and GMCF. Now, coming to thrombopoiesis. How do you increase the platelets? By increasing the interleukin 11. At least remember one drug. This is oprelevicin. You can see here in the name itself we have 11. Yes, it is oprelevicin. These are oprelevicins. Yes, that's all. This is what I want you to remember. Yes, in this I want you to remember epoietin, darbopoietin, filgrastim, sargramostim and oprelevicin. These are most commonly asked drugs in the exams. So, this finishes our hematopoiesis chapter, the hematology chapter. Yes. Now,